Dr. Jose Cabassa is a Parkinson specialist, former assistant professor of neurology, and he runs a private practice, Moving Brains Neurological Care. And he is the president of the Moving Brains Foundation, a physician-monitored moderate to high intensity skill-based exercise fitness program run by professional athletes. The goal is for Parkinson's patients to receive comprehensive care to improve quality of life, stop Parkinson progression, and decrease falls and/or injuries. His program has been safely running for more than 3 years in East Harlem, New York City. Thank you so much for joining us today, Dr. Cabassa.
Thank you for having me.
We'll let you share your screen to get started.
Okay, very good. Let me go ahead here and set things up. Okay.
Perfect.
Beautiful. So hello. So thank you for having me. Just kind of quick disclosures with something that you already mentioned, that this talk is meant to be informative. I can't give any specific medical advice, but hopefully this is going to be relevant to really everybody, all the attendants, and I'm happy to absolutely answer questions at the end. And I'll try to make this as straightforward but fun as possible. It is an important topic, and I think that it's I really am appreciative to have this platform. I also know that there's been some prior live streams about orthostatic hypotension, so that's something that I will kind of be building on as I cover this topic. Okay. So I'm just going to talk about blood pressure, pulse, and Parkinson's, and how we maintain flow to our moving brains. Now, let's see if I can make this work. Here we go. So another disclaimer, and before I move forward, is that I'm not even though I'm going to talk about blood pressure, I'm not a cardiologist. I've just been as a neurologist, I've just been very interested in really how the brain and how our nervous system, regulates things like vitals, like our blood pressure or heart rate. So that's kind of my disclaimer. I'm not, but I've been studying this now for a good amount of time, and the question is, so why is this important to me? And I think when we talk about Parkinson's and blood pressure problems, the real importance is that when you combine the two, we do see that there's an increased risk of falls, and that includes all types of falls, including, injurious falls that cause people to break bones or cause any other injury. When there's Parkinson's and blood pressure problems, we do see an increased risk for dementia, and it's about 14% per year. It's an increased risk of heart attack and stroke. And it decreases the quality of life and survival. So certainly something very, very important, and that we need to figure out. And we'll be talking about what's kind of the problem here. Now, thanks to one of my harshest critics, my mother, she always wanted me to add, always put within this talk something that we can always do. And you're gonna see it in each slide that whenever I'm talking a lot, there's always gonna be, you can always stare at the red. And those are going to be take action points. And instead of take home points, I'm going to give you take action points. What are the things that we can do to either inform ourselves or take hold of what's happening to us, so we can start feeling better and understand the situation. So really, what's one of the problems when we talk about blood pressure and Parkinson's? And I think in general, well, the problem is that we're really staring at the tip of the iceberg. So I'm going to go ahead and move forward here and show you this graph. Now, just focus on the top part of the graph. We'll come back to the bottom, but here, this is a tracing of a person that has dysautonomia, which I'll come to define. So they have difficulty regulating their blood pressure, and this is a 24-hour tracing of their blood pressure. On top here, the red, this is the systolic blood pressure, which we'll talk about as well. So the top blood pressure when they measure our blood pressure. And as we see, this seems to be fluctuating and moving up and down throughout the day. And at bedtime, we see that other things are happening. but ultimately, when we go to the when we go to our doctor, and they take our blood pressure while we are at rest, while we're sitting, we're just getting a measurement that might be close to normal, might be a little bit high, might be a little bit low, but it's really just one little peak out of this entire process of what's happening throughout the day. We're just measuring one little peak, and in most cases making almost lifelong decisions about blood pressure based on what we can infer from this peak. So that, I think, is one of the problems, is that blood pressure itself can be fluctuating or can be changing throughout the day, and depending on what's normal and what's not is whether this is gonna actually become problematic or not. So again, we're just looking at that little tip of the iceberg. It's just like one snapshot in time. And I think this is one of the things that starts creating problems. So, but we're gonna try to become smarter and resolve them. Now, first we unfortunately have to go back and we gotta review. We gotta review, and we gotta go back to just basics. So what is the pulse? And pulse is really the heartbeat. When we feel the pulse in our arm, we're getting arterial pulse. We can get it often in our hand. We can get it in our carotid, but really that is the heartbeat. That's the transmission of the heartbeat on the arterial wall. So when we talk about pulse, we're really talking about heartbeat. And when we talk about heart rate, it's how many beats per minute. Just like we can calculate dance music as beats per minute, our heart also beats in a rhythm. And a normal rhythm is what's called the normal sinus rhythm. So our heartbeat, typically beats between 60 to 100 beats per minute. So what that means is that for every beat, so for every minute, let's say that that our heart is beating, let's say if it beats at 60 beats per minute, we're creating 60 blood pressures per minute. And if it beats any faster than that, we're creating more blood pressures. But one thing that we know about when we talk about pulse and the heart rate is that with the lower at rest, the more efficient it seems to function. So just a basic sort of concept about of the heartbeat. Now, blood pressure, that's another thing that we always go to that's one of the things they always check out when we go to the doctor's office. So what does that mean? Well, blood pressure is the force of blood pushed on the artery walls, and that is caused by the heartbeat. And when we get the top number, the systolic number, that's typically the pressure that's created when the heart is contracting. That's called the systolic blood pressure, the top one. And then the bottom one is when the heart is relaxing. We got the diastolic. So that's where these vitals typically come from. And ultimately, what's the goal of all this? The goal of all this is to, the brain and the body need a steady supply of oxygen and nutrients to function. So the goal is to always provide this, in a continuous basis. So, if we're like cars or machines, once they turn us on, we got to stay on, until the end. And so the blood pressure, the heart has to always keep beating, and it has to be, supplying our bodies and very importantly, our brain with oxygen and nutrients. So how do we adjust, through a 24-hour cycle? And when we talk about 24-hour cycle, that's, we're talking about what do we do? What do we do when we live? We are sleeping, we get up, we have to get up and go to the bathroom. We got to get up and eat. We got to get dressed. We got to get out of the house. We might be running. We might be walking. We might be driving a car. Then we get up, so in all these life situations that we do every day, our blood pressure and our heart rate have to be continually adjusting for us to maintain. Really, what we want to do is maintain blood pressure or perfusion through all our organs throughout the day. So our goal is maintain blood pressure as steady as possible. So one of the ways that we can do this is that our heart rate must adapt. So in order for flow to continue, as our blood pressure might drop a little bit or go up a little bit, in order for our brain always to constantly receive blood and which gives us oxygen, nutrients, we need our heart rate to adapt. And now we know that we have something, we can measure something called heart rate variability. And that is something that down the line is going to be a very important sort of measure of fitness, not only in people with Parkinson's, but really in anybody, anywhere from using it to measure performance in athletes to our performance as we age. And as I've been talking about all these things and all these concepts, you know, one evidence that our heart rate is variable is what's called a respiratory sinus arrhythmia. And what that means is that when we take, all of us have this, when we take a deep breath, our heart rate speeds up a little bit, and when we exhale, our heart rate slows down a little bit. So you know, and how much heart rate variability we have, it's been linked to things as just, again, fitness, and the opposite, the lack of heart rate variability is associated with things like cardiovascular disease, so heart rate, stroke, and things like anxiety and depression. So I mentioned the take action points here, and you know, here we added the tap to relax. So what do we do with all this information, with all this heart rate variability information? Well, one thing that we can do with this is take advantage of it. And we have now, it's almost called a protocol, referred to as the physiological size. So if our heart rate is fast, if we're anxious, if we're stressed, you know, one thing that we could do and take advantage of, you know, with this knowledge is to then, you know, if breathing in speeds up the heart rate and exhaling slows down the heart rate, let's try to breathe where we have a long exhale and a very fast inhale. So the physiological sigh is something that's well proven, where you take 2 fast inhales to fill up your lungs, and a long exhale. And as you're doing that, and you can do it repeatedly, you're using this heart rate variability to bring your heart rate down. And it's one of the fastest ways ultimately to treat, you know, if you're anxious or going through a panic attack. This is one of the things that we can use, you know, take advantage to kind of help us relax, help us bring that heart rate down, you know, knowing that we have this this ability to do it. And how do we do it? You know, the heart beats automatically. It's a machine, but how do we adjust? How does the heart adjust? How does it have variability? And that's where the nervous system comes in, you know, and very specifically here we talk about the autonomic nervous system. And when we divide up the autonomic nervous system, we typically divide it into sympathetic and parasympathetic. One system, it helps us become more alert, the fight or flight response, and the other system helps us relax, the rest and digest. So as we're, let's say, in a stressful situation, if we apply this protocol at physiological side, we're forcing ourselves to pushing ourselves into more a parasympathetic state, more relaxed state by doing these long exhales. So that's where this comes from. So again, so a little bit of information about what are we talking about when we talk about heart rate, blood pressure, and how does it relate to adaptability that we're going to need to really, you know, go through the 24-hour cycle. So now talking about variability, let's talk about this. So we are moving brains. We need to adapt. So as when we go to the doctor's office, you know, we sit down and they take our blood pressure, and the best way is after you've rested, you know, after a certain amount of time, and you know, they give us this magic number 120/80. You know, 120/80. That's what we, you know, we all many of decisions are taking based on this number. But the main thing about this number is that this is the blood pressure at rest, and that's the most important thing. Why? Is because our blood pressure does vary normally when we do things. So quickly when we stand, our blood pressure goes up a little bit, then it goes down a little bit, and then it recovers. And within 20 to 30 seconds, it's up just about the same number as if we're sitting, as we're standing. But to get to that point, it goes through an entire process. Now, when we're doing other things that we are actually even told that it's good to lower blood pressure. So to treat high blood pressure, we must walk, we must exercise. Well, while we're actually walking, because the heartbeat is beating faster, our blood pressure does go up a little bit, and that's normal. And the more effort we put, the more intense we exercise, the more the heart rate goes up. As the demands to our muscles are increasing, the more the blood pressure goes up. And in some cases, you know, the top number while we're exercising can actually get to these scary numbers that at rest would probably send people to the hospital, or at least you know, lead the doctor to repeat the blood pressure to make sure that it's coming down. So, you know, the top number can get, you know, anywhere from 160 up to 220. So pretty high. But again, as we're exercising, now when we stop and where we're resting, that blood pressure is supposed to then normally start coming down back to, you know, just about what we had at rest. Other situations that we have to encounter pretty much every day is that we got to eat, and we got to go to the bathroom. So you know, when we, you know, and depending on where we at in the process, if we are in the process of needing to go to the bathroom to urinate, once that bladder is full, it does tend to increase our blood pressure and our heart rate a little bit. And then having a bowel movement, is another process. And we often even use this maneuver, it's called the Valsalva maneuver, to measure the autonomic nervous system, because it goes through an entire process where it goes up, it goes down, it starts recovering, goes down a little bit, and it recovers again. So it's more complicated. But it's a fine interplay of the blood pressure and the heart rate. Again, they're not staying static, they're changing. And being aware of this is going to be important. And we'll come back, you know, specifically to as it pertains to constipation and Parkinson's, how this can cause some problems as well. As we're eating, for example, it's another phenomenon. Our heart rate does go up a little bit as we're pushing more blood into digestion. But our blood pressure can go down, and this is you know, with a large meal, a lot of, you know, we know that, you know, we have to be very careful when we get up, you know, because our blood pressure might go down, and in some cases it might go down very significantly. Now, as we're talking about how our body adapts, we've talked about waking hours, and certainly we focus as doctors, we really focus on waking hours, but another thing we have to remember is that we have to sleep. Now, a take-home point from what I was just saying is that because the blood pressure throughout the day is fluctuating, it can change. You know, if we take blood pressure multiple times during the day, we start to fill in the picture, right? I mean, we start to at least fill in the picture of going back to this graph. You know, at least we start getting a few more peaks in here. So we start getting a little bit more information. So I think this is going to start becoming important, right? So now when we're talking about sleep, and there's a lot of work recently that's been done on sleep, and a lot of different physiological processes and what happens to the brain during sleep. One thing to really think about, and which is going to be a take action point, is that when we're going to sleep, our blood pressure and our heart rate and our temperature typically have to go down. And I think that's really one of the most important things that I use as a guide when I practice as a physician, is that what happens during sleep, because we don't want to mess with sleep. You know, we don't, just like we don't want to mess with Texas, we don't want to mess with sleep, because major things can come when we really start disrupting sleep. And as we've gone much smarter, we know now that in some of these processes in non-REM sleep, in very specifically in deep sleep, it's very important for memory. And when we're talking about REM sleep, which is the sleep stage where we're dreaming, it's actually very important for blood pressure and heart rate regulation. So you know, always focusing on sleep and trying to fix whatever problem there might be is really worthwhile, because everything you do during the day can be undone by having poor sleep and by having disrupted sleep, and within different conditions disrupt different stages of sleep. So again, the take action point here is that we really need to think about our nighttime vitals. When we're going to sleep, you know, are we setting ourselves up for our blood pressure to go down, for our heart rate to go down, and for our temperature to go down. And we can do that, and we can be mindful of that as well. So now let's talk about Parkinson's. Now, Englishman that keeps on giving. So when we talk about now, blood pressure and Parkinson's, and in which we already had a talk about neurogenic orthostatic hypotension. We know that it's a non-motor symptom of Parkinson's, it can be a common non-motor symptom, and it's lumped into this term called dysautonomia, which is dysfunction of the autonomic nervous system. And when we talk about dysautonomia, it does include orthostatic hypotension, but it includes a host of other things, and that includes constipation problems, urinary problems, things like sexual dysfunction, sweating changes. And then I mentioned very specifically here, unstable blood pressure. Rather than jump in and say neurogenic orthostatic hypotension yet, I think the concept is that it's unstable blood pressure. Because as we'll see, it can go down, but it can also go up. And I think, as you look at this list of dysautonomia, it's like the greatest hits of aging and all the stuff that can start to happen, as we age. And another important point that I maybe failed to mention in the slides is that as we're dealing with dysautonomia, and as we're dealing with this problem as it pertains to Parkinson's, we also have to remember that dysautonomia is also common in other things, or other conditions can affect blood pressure that are potentially even more common than Parkinson's, and those include things like diabetes. So adding diabetes to the equation here, can make things even worse. And certainly, and hopefully, if we all get there, part of the risk factors for dysautonomia is just normal aging. So as we age, these are some of the challenges that we're starting to face as our autonomic nervous system also starts slowly becoming dysfunctional. So, the Parkinson's just makes, it's a feature, but we got to always remember that it might not just be the Parkinson's causing these problems when we talk about dysautonomia. So here, and I have to, let me see, I'll move a little bit my cursor here. Very good. So when we talk about blood pressure and Parkinson's, we're talking about cardiovascular alterations. And within those, about 80% of Parkinson's patients have some sort of cardiovascular alteration. Whether it's recognized to be part of Parkinson's or not, I mean, that's one thing, but we're recognizing, how prevalent and how common it is to have blood pressure problems or even heart problems when you have, along with Parkinson's. So, cardiovascular dysautonomia is what we talked about, which is really the unstable blood pressure, the difficulty controlling blood pressure. And as a result, we might develop what's called neurogenic orthostatic hypotension. And now that's what we talked about in the last live stream, where about 40% when you take a cross-sectional area of patients, about 40% of Parkinson's patients might have neurogenic orthostatic hypotension. It's a mouthful. And then about 80% of patients with multiple systems atrophy have this feature. Now, multiple systems atrophy is very rare. So really, anybody with Parkinson's, I guess, and we're going to, one of the take-home points is that we should all be checking for blood pressure variations. But we're certainly going to encounter this problem, as a physician, I certainly encountered this problem much more in Parkinson's patients, because I barely see any MSA patients, for example. But again, just remember that this can also increase if we're talking about as people are aging. Maybe somebody with Parkinson's right now might not have neurogenic orthostatic hypotension, but maybe in a couple of years they might develop it. And so being mindful about this and knowing about this, I think it's important now. And I think one of the most important parts of this talk is to try to recognize again that this dysautonomia does not only cause neurogenic orthostatic hypotension, but one of the major problems is really supine hypertension. So what typically happens is that as we get up and we stand up, our blood pressure might plummet or might drop, and we might have issues related to that throughout the day. Then on top of that, at night, when we're laying down, in some people with neurogenic orthostatic hypotension, their blood pressure might also be dangerously increasing. And that's called something as supine hypertension. So about 20% of, so I believe that it's about, about 50% of the 40% of patients with neurogenic orthostatic hypertension can also have identifiable supine hypertension. Now, the problem with this, and the problem that I find often when I'm seeing patients, is that I'm not there with them at night. I'm not there with them, as they're laying down, checking their blood pressure. So how do we try to identify this? And that's something that we'll talk about very soon. But this is one of the problems is that we still have to think about us in 24 hours, right? And not just when we're awake, but what's happening at night. Because we actually might be having dangerously high blood pressures and not really being properly treated for them. Now, another concept that goes along with supine hypertension is called nocturnal non-dipping profile. Now, this is something that the cardiologist, this comes from the cardiology literature, and ultimately recognizing that it's normal for us to lower our blood pressure and lower our heart rate when we lay down to sleep. And the people that are not dipping, they're not lowering their blood pressure, that are not lowering their heart rate when they're lying down, they are more likely to be, they're at a much higher risk for heart attacks and stroke and heart failures. So this is coming from the cardiology literature. Now, the difference here is that it might not, the blood pressure itself might not increase, right? It might not be supine hypertension. It might not go into a high blood pressure range, but the fact that if it stays the same, it doesn't go down, we think that it still creates a problem. So that's, I guess, the difference between the nocturnal non-dipping. You cannot dip, but still remain in a normal blood pressure, waking blood pressure, but that's still a problem, and it should be dipping. And then lastly, the postprandial hypotension. This is after we eat. What happens, that our blood pressure can become very low when we have dysautonomia. Our blood pressure can become very low. Then when we stand up after a meal, we can get dizzy and pass out. Now, just to mention this, and it shouldn't be just a little aside to mention, but something to look at, because we are starting to look at this more, is really the relationship of Parkinson's and things like heart failure and cardiac arrhythmias, because there seems to be a higher incidence of heart failure and Parkinson's, but it's not yet very well, I guess, studied. Now, I've talked a lot about this about this slide, but the take action point here is that if you have Peter, worry about Paul. So meaning that you have orthostatic hypotension, you should worry about supine hypertension. Whether you have it or not, just worrying about it starts making you think about a potentially dangerous condition, and maybe this can alert your doctor. Because ultimately the way that is being described when we don't recognize dysautonomia, it's the analogy of a volatile stock market. And this was from a study that was published in Neurology this year, and there's an editorial about this study, where again they showed the tracings of a person. This person did not have Parkinson's, had a MSA, but had dysautonomia. So presumably a person with Parkinson's may have a similar profile. Shows how they were up and down, throughout the day. Their blood pressure would be, maybe around here, in the 120/80, but certainly, drop dramatically into the, the systolic blood pressure. The top blood pressure would drop, all the way down maybe into the 70s, and then maybe go up as high as to the 160s. So a lot of fluctuation. And when we see here at night, when we get to the bedtime, we see that, the blood pressure rising and giving rise to what we were talking about, which is supine hypertension. So again, so this is the entire iceberg. We're just looking at the tip. And this iceberg looks worrisome. And the analogy is like it's like a volatile stock market. All right. So what are the challenges? So what are the challenges of really, how are we going to deal with this? How are we going to recognize these problems with Parkinson's, and how are we going to treat it? So first, diagnosing, or recognizing, and I think we, over the last live stream, we went over the symptoms of what people, when you have neurogenic orthostatic hypotension, what might you feel? Well, as you stand up, people can describe feeling dizzy, feeling lightheaded. Another term that I hear a lot is brain fog. You might have just generalized fatigue. You can have even chest pain or shortness of breath. You can have what's called a coat hanger headache, where you feel this pressure in the back of your neck and your head, so as if they're hanging you from a coat hanger. You can have darkened vision, but the maybe the most concerning symptom of all of this is that in some people it's asymptomatic. You don't have any symptoms. And in some cases, it means that the body's trying to adjust, or you're just at that edge where if you drop your blood pressure more, you'll develop symptoms. But you're still in a way stressing your body. You're still stressing in a way you're still stressing your heart by having these changes, and your body continually trying to adapt to larger changes. So part of also how are we gonna I guess even characterize the problem when we talk about the definition of what's neurogenic orthostatic hypotension. It's a 20 systolic point in your 20 point drop in your systolic blood pressure, and a 10 points diastolic drop after 2 to 3 minutes, right? So that, that's the definition, that at 2 to 3 minutes, when you check the blood pressure again, that blood pressure has not recovered. It's still lower than what it should be. And I guess one of the practicalities of this definition is that for the most part, not only is the doctors or in doctor's offices not checking the second blood pressure, but even if they check it, we typically waiting for that long, might not be realistic. And now, but at the same time, if we check it very fast, another thing that could happen, which will fall kind of outside of what's called outside of neurogenic orthostatic hypotension, is that you still might have a delayed blood pressure recovery. So maybe when you stand up, your blood pressure drops, and it takes a long time to recover, but maybe by the 2 minutes or 3 minutes, it's recovered. Right? So here we don't have orthostatic hypotension by definition, but in this scenario that I presented, there's a delayed blood pressure recovery, where the blood pressure after the first, let's say, 30 seconds of standing is not recovering. Well, what we found out is that it actually confers probably the same type of risks that neurogenic orthostatic hypotension confers if we don't recognize it, is that it still seems to increase the risk of falls, it still increases the risk of dementia, and very particularly increases the risk of you going from mild cognitive impairment into dementia, and it increases all these other cardiovascular endpoints like heart failure, heart attack, and stroke. So this is a problem, and this is a problem, I think, that that is by convention, is about what the tools we have. We, unfortunately, when we're dealing with blood pressure nowadays, we're still in the caveman ages and the cave people ages, and on top of that, the way we just check blood pressure, then we're even we're even tying one of our hands back. So how do we resolve this? Well, how do we can, as advocates for Parkinson's patients, how can we solve this? Is to always take blood pressure sitting and standing. Just always do it. Don't wait till you have symptoms, because again, it might be asymptomatic. It might already be occurring, and these processes might already, these risks might already be increasing, and you don't want to wait till we get symptoms. So we want to create this, I guess this this behavior where we're always checking orthostatic blood pressure. Now, once we check orthostatic blood pressure in everybody, if we find that somebody has orthostatic hypotension, if they're dropping their blood pressure as they're standing, is that a surrogate marker for supine hypertension? So if we're dropping our blood pressure, should that be a sign that we should be worried about high blood pressure at night? And again, I already suggested that we should be. But how can we know? How can we, instead of just worrying and not knowing, how can we take action? And I think this is another thing that's being looked at more is how much are you urinating at night? So nocturia. Now, of course, in men, that's a little bit more difficult because of the prostate. But we do know that at night, if you are urinating at night, if you're waking up more than maybe more than once, one of the things that might be occurring on top of all the regular things that might occur, more of the common things, is our blood pressure high at night. So it's the clinical clue that we have that we can hopefully bring to our doctors or start exploring ourselves to see why. And the idea here is that it's yes, if you drink a lot of water before going to sleep, you're going to get up more, but it's much more than that. Even if much more than that, because the process of, as I mentioned, it's abnormal to have a high blood pressure at night. So ultimately that, with high blood pressure, it just creates more urine. Ultimately, your body is revved up and you create more urine, no matter how much water you drank. That if your blood pressure goes high at night, you're gonna just create more urine. You're gonna get up more. So thinking about the problem when we think about blood pressure, again, thinking about high blood pressure at night, how are we gonna deal with this? And one of the problems, and I'm getting to the end here, and again, we're gonna go over the take action points in more detail very soon. And one of the other problems that we have when we're talking about blood pressure is that we have too many cooks in the kitchen. And what I mean by that is that, we know that a lot of the contributors to orthostatic hypertension might be the actual blood pressure medications that we're getting if we're being treated for high blood pressure, or any other or many different other types of medications, things for bladder, for example, for urinary frequency. They can make blood pressure more unstable. Even the Parkinson's medications can make our blood pressure a little bit unstable. When we take levodopa, our blood pressure does go down by a little bit. So how are we going to deal with that? And taking a close look at all your medications is really one of the first solutions to this problem. Now, I put this here, and I apologize. I'm trying to move a little cursor out of the way so I can read, but one of the problems of treating when somebody has low blood pressure when they stand is that when we treat neurogenic orthostatic hypotension, is that it can actually make worse the supine hypertension. So when they read us the list of, oh, okay, I have neurogenic orthostatic hypertension, that big mouthful, I'm getting dizzy when I stand up, I don't feel good when I stand up, so what is one of the solutions? Well, what the book tells us and what we always say, we go through the list of medications that we use to help raise blood pressure, and those include things like midodrine, those include things like fluticasone, and now more recently we have something like droxidopa, and we also can use pyridostigmine. But ultimately, the problem with these medications and often their limited use is that they ultimately may worsen supine hypertension, some more than others. But it really makes them really in the long-term use a lot more limited in terms of how can we use them. And a lot of patients who are on these medications can a lot of times attest to that. Now I think that the tab below this I cannot see, but I'm trying to look at my other screen here, and which I think I already mentioned, is to worry about urination at night. So if you're peeing at night, this is one of the best clinical clues we know of right now about high blood pressure and specifically supine high blood pressure, so blood pressure when we're laying down. So again, it's something we really should be paying attention and not just chalking up to we're just drinking a lot of water. Because yes, if we drink a lot of water, we'll urinate a lot at night. But I often use this example is that if you and I both are going to sleep and we both have the same amount of water as as we're going before we go to sleep, if your blood pressure goes down, then your bladder will slowly get filled throughout the night. But if my blood pressure goes up, then that bladder is going to very quickly get filled. Same volume of water, right? But different results if my blood pressure doesn't go down or stays the same at night. So very important concept. And ultimately, we're going to come back to it, and in terms of the take-home points. So getting to the last, here we go, the take action points here. So what are we going to do when we're learning about blood pressure, these problems of unregulated blood pressure? How are we going to tackle them? Now, if we already know we have neurogenic orthostatic hypotension, if we are suspicious that we have it, or we're worried about it, the first thing we need to do is drink water. And that's, of course, we all know that we need to hydrate. But really, drinking water in the morning, first thing in the morning, is one of the best sort of practices to do. That's when the body tends to be the most dehydrated. And trying to get, I typically tell my patients 16 ounces of water upon waking will really help set up the rest of the day. You have to stay hydrated throughout the rest of the day, but starting out the day, with 16 ounces at the very least, I think helps. And these are also Mayo Clinic recommendations, as they've noticed that with that amount of volume in the morning, it really prevents, a good amount of blood pressure drop for the next 4 to 5 hours. During these morning hours, where most people is when they tend to feel most dizzy, when their blood pressure tends to drop the most. In some cases, not in everybody, and this is where you should discuss it with your physician, salt might be your friend. So you might be drinking a lot of water, but your blood pressure might still drop. You need to add a little salt to your diet, and especially people who don't have heart disease or don't really are suffering from high blood pressure, adding a little salt, a little electrolytes helps. And again, this is not necessarily something new, but it's something to just be mindful of. Eating small, more frequent meals. I think that's to avoid a big meal and cause this big drop in blood pressure when we stand up and cause a big show when we're in a restaurant. Or where we can pass out. But another sort of point is really treating constipation and avoiding straining. I mean, we always, as a Parkinson specialist, I'm always aware that constipation is part of Parkinson's, and it's even harder to treat in Parkinson's patients. But recognizing that if you have dysregulated blood pressure, and you're constipated, it could set yourself up for disaster, because as you're straining, your blood pressure can go down so low, then it could lead to passing out. It could lead to different things, even heart attack or stroke, or as the straining, the effort causes a big blood pressure drop. So a very important, very important point here. Now, another thing I mentioned is use your muscles, and what do I mean by that? And I put this down is the recommendation that I give my patients when what happens that if you're feeling dizzy now, you're walking in the street, you start feeling dizzy, what are you gonna do? And what I say is use your muscles. And what do I mean by that is that if you're standing, walk, start moving, do not stay still. When we're standing upright, the only thing that typically that's helping us, our blood flow through our body, is the pumping action of the heart. But once we start moving, the muscles start helping us pump some of that blood back to the heart and back up to the brain. So if you cannot, of course, if you start feeling dizzy and you can sit down or lay down, that's typically what we recommend. But if you're standing and you don't have a place to sit, what are you going to do? But one thing is just to first move, whether you can just start walking, whether you can march in place if you can't move around. Another thing is to start pumping your fist, start trying to crunching up your toes, try, kind of pressing down. And if you have something cold, that causes it causes blood vessels to vasoconstrict, to become smaller. So all these little things that you could do as you're becoming dizzy, you have to think about use your muscles. And again, with this problem of having low blood pressure, the oral medications are difficult. They're very limiting. We don't want to rely on, getting this problem out of hand to the point where we need to now depend on these medications, because they're going to cause a whole other set of problems. Now, when we're talking about high blood pressure, and specifically supine hypertension. So again, if we have orthostatic hypotension, if we're dropping our blood pressure, we also have to worry that our blood pressure is going too high. What can we do about it? We have to scrutinize our blood pressure medications if we're on them. If we're on blood pressure medications, we should be going back to our doctor and really scrutinizing them, asking them, hey, should I still be on this blood pressure medication? If I am on one, should I be on this type of blood pressure medication? And if I need to be on this type of blood pressure medication, when should I take it? Is it better to take it in the morning, or is it better to take it at night? And sometimes that can make a big difference in whether you are going to develop these changes. Sometimes we can use knowing that this phenomena is occurring, we can use it to our advantage to better target how we manage blood pressure, even as a regular doctor or cardiologist can. So the last couple of points is monitor and treat sleep problems, and anything that messes with sleep can worsen orthostatic hypotension. So because ultimately what it's doing is it's disrupting these vitals that we really need to focus on. When we're going to sleep, our body has, our blood pressure, heart rate, and temperature have to go down. So if you have sleep apnea and you're having, sudden episodes of snoring, and you stop breathing and you start breathing again, so that causes a increase in blood pressure, increasing in heart rate. So that's disrupting it. If we have REM sleep behavior disorder, something that's common in Parkinson's, and we're moving around, we're acting a dream, our bodies at that point, our heart rate and our blood pressure is going up. If we can't sleep, if we don't have regular sleep, we're disrupting regular sleep. We have insomnia. We're really, we're messing those vitals that we need for really our body to work the next day. And if we're in pain, I mean, we don't have to have any specific disorder. We can just be in pain, and focusing on managing pain, when you're going to sleep is going to become important. So again, monitor and treating sleep, very, very important. And last but not least, to treat high blood pressure, to treat low blood pressure. And when we get to the nitty-gritty of things, what's happening in Parkinson's, when these nerves that are being affected, the nerves that go to our heart, can we do something about it? And we do think, that exercise, high quality exercise, can help, enhance these nerves that are dysfunctional. We think that they might be able to, in one way, maybe regenerate or sprout or become more functional again, so we can retain some of this heart rate variability that we're all losing, whether it's through age, or whether we're accelerating, we're losing it through an accelerated process like Parkinson's. At the end of the day, the exercise is going to be very important, and often, if you just combining all these pieces of information, it's somebody that has neurogenic orthostatic hypotension, there is hope, and they can actually do quite well, and even before getting to the oral medications. All right, so I think that I'm going to leave it like that. I've talked a lot, and I'm happy to answer any questions that you guys might have.
We have a lot of questions.
Yes.
So first, let's start, because there were, one is just a basic, at what point is the blood pressure too low? Like, as a norm, not like, just if you would say, like, if it gets to this over this, we have a problem.
Right. So the problem with giving a static number is just that, is that everybody lives in different blood pressure ranges. And that's why it's very difficult. And it's very difficult to just go by one number. You know, and to determine that also requires some testing that unfortunately it's not something that insurance even pays for it. So it's something that really it's per patient. Now, of course, if your blood pressure is going low and you have symptoms, that's too low. But if you're seeing a trend, even if you don't have any symptoms, but as you stand and you're dropping, you're significantly dropping your blood pressure, I think that rather than looking at numbers, it's more fruitful to look at trends. You know, so every time that you get up, if you stand up, it is starting to go down, and eventually you develop symptoms, or even before that, then I think that you have to be mindful. And at that point, you know, we're not telling you to start any medication. We're telling you to, you know, be mindful about what you're drinking, you know, your hydration status, and depending on what condition you have, whether you have to add or salt, for example, or electrolytes.
Questions about sleep. Somebody said you kind of talked about the importance of sleep, but so many people with Parkinson's have REM behavior disorder.
Right.
So how does one deal with that? And then also somebody said we constantly hear about getting adequate sleep, but there are some of us who only get 4 to 5 hours of sleep. Is that okay?
Right. So what we could best do, and this is you know, what we can best do is just try to tackle, not ignore sleep. Just make that a problem, you know, in your problem list when you go see the doctor, and not necessarily be satisfied if you're not getting help there. I have to admit that, you know, sometimes sleep, we don't, you know, doctors just don't get to talk about sleep, you know, when it might be more important, but treating around it too. If I know you're in pain, you know, I want to know what's happening to the pain where you're going to sleep, because that, you know, that can then interfere with sleep. So so just trying to figure out, you know, each individual person, what's the situation, try to do the best that they can, of course. Not all of us are going to get the 8 hours of sleep. Not all of us need that, but what we need is good quality of sleep. And there are things we can control and things we cannot. Now, the temperature, for example, well, you know, we can maybe control the temperature of the room. So, you know, making sure we're at a comfortable temperature. The reason why a lot of people take a nice warm shower before going to sleep is that when you come out of the shower, it helps cool off your body. So, you know, so that's something maybe that we can have a little control. Thinking about blood pressure, you know, is your blood pressure too high? Well, maybe the blood pressure medications need to be changed to taking them at night. Maybe instead of taking a pain medication during the day, maybe you should take it at night. Again, just thinking about what can you do, either, you know, the person themselves or with the help of a physician, how to tackle any problem to improve sleep. One thing that I did not mention is that if we are worried about supine hypertension, we do mention people that we want them to elevate the head of the bed 30 degrees. So these are all just little things that we could do, but it is a challenge. It's not I don't have a magic pill for that, but it's just really putting everything together. You know, to really maximize once you go into sleep, that's when, you know, make sure that the quality of sleep is there. You're setting yourself up to have the best quality that you can have.
Some questions about, can either SAH or NOH, can they affect eyesight, and can they affect kidney function?
Right. Great questions. Now, you know, in the when somebody drops their blood pressure and past a stage, past a level, let's say, sorry, if it goes low enough, then you know, there's less blood going in, getting to your brain. So one of the symptoms that people describe is that they have darkened vision. So that's certainly one way that with, you know, acutely, when when blood pressure drops too much, you start feeling dizzy, people can describe the darkening of vision. So acutely, there can be vision changes. Now, whether this has been fully worked out or not, I'm not aware. I know it's trying to be worked out, but certainly when we talk about the risk of having dysautonomia in heart failure, then we also think that yes, it very likely could also be contributing to renal function. So just like high blood pressure, because what we're talking about is that, you know, it's not just now high blood pressure, but it's these swings of low to high blood pressure. And we know that these swings, whether we feel them or not, is what typically drives something that's called white matter disease. So when we all get brain MRIs and after a certain age, there often there comes this line that says we have mild microvascular ischemic disease. These are what's called white matter lesions, and if you have more, and that's typically normal of aging, but if you have if it's out of proportion to your age, if you have more, then that's bad. That we think that predisposes people to more cardiovascular events, and we think then the mechanism is that the blood pressures is swinging, and it's just not that it's staying high and sustain high, but it can stay high and sustain high, let's say during the night, but then during the day it's going up and down, and it's really it's concerning. It's something. It's the reason why I make this an important part of my exam when I examine somebody with Parkinson's, and part of this really this live stream is to really try to create awareness and consciousness about how do we approach blood pressure. I think we need to do a better job overall. Because we might be missing all these issues that are driving risk, let's say, risk for heart problems, that maybe your cardiologist is dealing with them thinking that they have nothing to do with Parkinson's, or that they're not related. And I think that there is, we have plenty of evidence that these problems are related and that they're consequential. Just because you're dropping your blood pressure and don't have symptoms, I think it's not inconsequential. I think it's consequential, and it's an opportunity that we have to intervene and really help, as a doctor, our patients, but as a person, as a patient, help ourselves, recognize that we really have to take care of, the basic stuff, such as hydration, such as good sleep, because of the tremendous impact they can have into our health, as it affects, as it pertains to heart rate and blood pressure.
We're running out of time, so I do just want to ask a couple of more questions. Somebody asked, like, what tools can we use to monitor all this? And somebody talked about accurate, valid measurements of blood pressure. What can we do to try and maintain this as best as we can?
Right. Now, I think that starting with the tools that we have, we just have to use them, so taking the blood pressure sitting and then standing in the doctor's office, should be done. And if it's not done, we can graciously ask, hey, can you also get my blood pressure standing as well? At the end of the day, I tell my patients, even if you have a blood pressure machine at home, just any basic type of blood pressure machine at home, really it doesn't really matter whether it's calibrated to your doctors. It doesn't really matter, how it's calibrated, because what you're looking for, at least with this issue, is a change. So by just using the same machine, just getting your blood pressure sitting and then standing, it doesn't matter where it's calibrated, because what you're looking for is you're looking at this change. Is it dropping? Is the blood pressure dropping significantly from when I just took it sitting to standing? So that's one thing that we have. And then the other sort of clinical clue that we have is it's what's happening at night. And if you're urinating a lot at night, is that one of the markers? But ultimately, by raising these issues, hopefully that would get us a referral to a cardiologist, and the cardiologist can use 24-hour blood pressure monitors. Not a lot of them, or not all cardiologists use them, but some do, and that can, the tracing that I showed is based on a 24-hour blood pressure monitor. So that gives us a better idea of what's happening. It's not as routinely used as I would hope that we eventually start using it, but we do, there is a, I think we're at a disadvantage, and we have to demand better tools to be able to monitor this a little bit more closely. Right now we're looking at the tip of the iceberg. We can now, by checking blood pressure sitting and standing, we're looking at the tip and a little bit of the slope of the iceberg, but we still have a whole iceberg to look at, and and that's going to entail a lot more monitoring that is right now is not routinely done.
You did mention about changing how you take the medication. So someone asked, how can taking the blood pressure medication at night differ from taking it in the morning?
Right, and this is something that I do in my practice, and that I, with the guidance of cardiology, first is thinking about what blood pressure medications that you're on. Now, certainly there are, one of the types is diuretics, and diuretics can often, worsen things like neurogenic orthostatic hypotension. So just within the first class, questioning whether you still should be on what type of blood pressure medication, thing like a diuretic, should you still be on a diuretic? And again, that's on a personal basis, but that's one thing to think about. Now, some blood pressure medications that are often given in the morning can sometimes be given at night. Now, if by switching those blood pressure medications at night, you target, if you're going back to maybe this figure here, if during the day what's happening is that we're going up and down from normal to low, and that this is when we're taking our blood pressure medications, maybe by targeting them at night when we expect the supine hypertension to kick in, maybe by targeting them at night, maybe we can offset that supine hypertension. And in my practice and in my experience, this is exactly what we do. And what happens is that when we are able to change some blood pressure medications from the morning to the night, the blood pressure starts becoming more controlled. Now, how do we know that? And more importantly, why would somebody to do this cares? Is because they'll stop urinating as much at night. So their sleep is going to improve as they notice that they're getting up less at night to urinate. So that's where the urination comes back as a clinical clue. Not only is the supine hypertension potentially occurring, but once we make these changes, are these changes effective? Well, one of the clues we have is that by switching them at night, then the blood pressure down. We're forcing now the blood pressure to become normal at night, which means that it should be lower than when you're awake. And so we're trying to mimic that situation to fix the situation. And lo and behold, we now know that these strategies of focusing on sleep we're seeing good results. So for example, if we change, so not only if we change the blood pressure medications at night, might the sleep improve because you are urinating less, but then in the morning, your blood pressure drops. If you're going to have, they tend to occur less precipitous. They start occurring less and less as your body's less dehydrated and able to, so your drops, become less. You start treating the problem. And there is some data now that treating something like sleep apnea with the CPAP machine improves neurogenic orthostatic hypotension. So now they're looking at that leap of focusing on fixing the problem at night to then seeing the results during the day without having, resorting to these blood pressure medications that raise blood pressure. The blood pressure, the neurogenic orthostatic hypotension is starting to improve just by treating the sleep apnea at night.
We are out of time, but thank you so much. This was so informative, Dr. Cabassa. We're so grateful you gave us this time today. We have a tradition here at PMD Alliance, our wave of gratitude. Thank you so much for doing this today, gifting us your time. Thank you.
Well, thank you as well. Thank you for having me. It's my pleasure.
Thank you.
Okay, bye.